Perfect. Okay, go ahead.
Okay, brilliant. Delighted to meet you all, and very excited that you've expressed an interest in learning a bit more about medicine and applying to medicine as a career. As Kwame mentioned, my name is Abhi Ghosh. I'm a histopathologist, and I'm a specialist registrar working at the John Radcliffe Hospital in Oxford, but I'm also a clinical lecturer, which means I deliver a lot of lectures to the medical students in Oxford, particularly during their year 4. So I wanted to talk to you a little bit about histopathology, but in terms of where you're at and where I think you're at the moment, many of you might be sort of considering a bit more about what doctors are and where does histopathology maybe fit in with that? Where do other specialties fit into that? Histopathology is not usually the first thing people think about when they consider a doctor. At least I think it usually isn't. And what I wanted to just ask is, where do you see, what do you see a doctor as? Where do you see a doctor as? I mean, we've got 6 different doctors on the screen. Anyone see themselves? Can you put your thumbs up if you're there with the reactions? If anyone can do that, that'd be great, just to see if people are able to interact with me. Brilliant. I've got some thumbs up. Fantastic. Who sees themselves as number 6? Anyone want to put the thumb up if they think, or a smiley face if they think they're on number 6? Number 5? We've got some. Number 4? Yeah, a few more. Number 3? Yeah, more there. Number 2? Even more there, I think. And number 1? Not many for that. Interesting. The reason I put this up is because what I want to emphasize to you is that basically doctors do come in all shapes and sizes. And certainly when I applied for a career in medicine, I didn't know. I didn't know where I was going to be. My vision of a doctor was probably more like number 1, to be honest. These are the sort of doctors that you see on TV, perhaps, in the UK not wearing the white coats, but those are the sorts that you see on TV. Perhaps you see in the papers, you see a lot of international outreach work, you see surgeons on TV. And the truth is, I said, they come in all shapes and sizes. And what it's important to keep in mind is that as people thinking about applying to medicine, don't pigeonhole yourself. Don't think that because you've got a certain set of skill, you need to have a certain set of preferences, a certain set of skills, a certain set of abilities to become a doctor or to get through medical school. There are many different skills which can be very beneficial, and we need a wide range of doctors to practice to actually to actually provide a good service for our patients. But the most important thing is that all doctors, regardless of who they are committed to doing the best for patients. Now, the first, when I sort of applied to medicine, I don't think I had a very detailed idea of exactly what my trajectory would be like. And I think my trajectory I thought it would look a bit like this. I would do my years of medical school, and then I would turn out to be my sort of prototype picture of a doctor, and that would be that. But the truth is, there's a long route. Medicine is a long journey, and there are many steps along the way, and applying to medical school is really the first step. So really, you should think about it in terms of a long and branching path. The medical school is the first step, usually followed by your foundation training, and that is usually followed by specialist training, usually sort of with interspersed periods of research, perhaps, education, fellowships, anything that you're interested in, you can inject within that career pathway. And there is no single straight line between you starting or deciding to apply to medical school and you become a fully fledged doctor at the end of the process. There are many, many paths, and these paths branch off at various points in the process and can lead to many of the doctors that you see in the photos that I've shown you. So yes, it's full of branching paths. And I wanted to give you a brief overview of my journey so far. So I started, I said, with that sort of perhaps slightly naive idea of what medical training would be like many years ago. I studied medicine in Oxford, and in Oxford, medical training is split into your preclinical medical years and your clinical medical years. In many other medical schools, they are not split in this way, and it's a combined they are combined into one large training scheme, but Oxford prefers to split it into these two segments. So a lot of people talk about the length of a medical degree, and certainly, in most places they are between 5 and 6 years. In Oxford, it is 6 years, 3 years of preclinical and 3 years of clinical medical training. So I went through that, and a lot of people were talking, oh, that's a very long degree compared to other degrees that are available to you. But that's only the beginning. That was for me followed by foundation years. So I did my foundation years in Bromley in South London, followed by Dartford. And in your foundation years, you do a broad range of medical and surgical specialties, which are designed to give you a broad overview of life on the wards. And that I followed that up with an internship and project year. Now, at that point, I wasn't totally certain exactly what I wanted to do, actually. And I had some ideas in my head, but I used the year following foundation year to give myself a better idea of what I wanted to do, try out a bit of histopathology, see if that was what I wanted. And then I applied for specialist training in histopathology and continued with that. So training in different specialties follows many different paths. Again, in histopathology, typically, like some other specialties, you follow a trajectory from beginning to end, which takes about 5 years. But in the middle of that, I decided that I really like teaching. And so I decided to apply for a clinical lectureship here to teach Oxford medical students. And I was lucky enough to get that post. And so I've been here as a clinical lecturer for about 3 years now. And I've still got 1 more year of training left until I'm actually eligible for the end of the journey, as it were, as a consultant. And one might argue that even as a consultant, there are many further routes for you to traverse, but a lot of people view consultantship as being sort of the boss doctor level. So it's been a long journey, hasn't it? So if you top this all up, I'm coming to 8, 9, 10, 11, 12, 13, 14, 15 years since deciding to apply for medical school. So I wanted to highlight that to you because I wanted to show you, that it takes a long time. It takes a long time, and it is not just medical school that you have to consider. It is the years beyond that as well. Okay, so we said it's a long journey. So I want to talk to you a bit about histopathology. And histopathology, as I said, is not something that many people consider initially when they think about doctors. A few of you did when we looked at the slides previously. But to illustrate what we do, I'm going to talk about a brief case. This is actually one of the cases that I look at in a slightly different way with the medical students in Oxford. So this is, oh, sorry, hang on. This is my case. So the case is a 32-year-old woman has noticed a lump in her left breast on self-examination and presents it to you. So you're taking the role at this point of her general practitioner. And she describes it as a painless mass, which is firm and about 2 centimeters in size. So I want to ask you now what you think. You have some thumbs. I've seen you do some thumbs ups. So who out of the attendees thinks that this lump is definitely cancerous? Anyone want to put their thumbs up? Anyone want to put the thumbs up for 2? Anyone think it's definitely not cancerous? No one's being brave enough yet. And is anyone unsure? We've got plenty of unsures, okay? So fantastic. So you've illustrated what happens in medicine. Patients will present to you with problems such as this, which are often things like lumps, surgical problems such as lumps. And it's your job as a doctor to decide what to do next. But it's not always easy. You're unsure, and most doctors at this point would also not necessarily be sure about what exactly was going on. Let's give you a bit more information. Doctors typically take a history and do an examination of their patients, and we've got the history we've discussed so far. But you examine your patient and you confirm that what the patient said is correct. The lump is as described. They also say that it is a smooth mass. It's mobile, so it moves around. The patient doesn't think the lump has changed in size over the past few months, but is not sure about that fact. Okay, does that change anyone's opinion? So anyone thinks now that this is definitely cancerous? Got one hand up, great. Anyone for 2 think it's definitely not cancerous at this point? Yep, we've got another hand up. And anyone still unsure? Okay, we've got 2 more hands up for unsure. Okay, so I'm glad that you've started to think a bit more deeply about this. So the way that doctors operate is by looking at the information that is available, gaining more information in this particular example through their examination, and then using that to guide what they do next. Okay, and the fact is, most of you have said that you're unsure. Okay, most of you've not said that it's definitely cancerous. It's not definitely not cancerous. Okay, so you're unsure. So how do we resolve this problem? Well, one way of resolving this problem would be through histopathology, and I'm going to talk to you a little bit about that. So histology, you may have heard the word histology. Histology is a study of normal tissue, and it's a study of normal tissue through the microscope. But histopathology is a discipline of medicine, and it deals with the study of diseased tissue. So it's both the study of macroscopic appearances of diseased tissue, so what it looks like through your own eyes. So for example, if you were to take that lump out of the patient, what would that look like? But it's also to do with microscopic study of that diseased tissue. And there's basically 5 sort of things that we can study. First is biopsies. So if we take a little strand of tissue out of that lump, so a little bit of material out of that lump using a large needle, and look at that under the microscope, that would be a biopsy. And that's how biopsies are interpreted and reported. Surgical resections. So for example, if you were to core out that whole lump, take it out and have a look at that, both macroscopically and microscopically, that would be what we mean by surgical resection examination. Frozen sections, so some specimens we are actually able to look at very, very quickly during operations if it guides the management of that patient. Cytology, so instead of using a needle to take out an intact piece of tissue, cytology involves, it's a bit like sort of sucking it out with a straw. You're sucking out some cells from that lump, for example, with a straw, and you're smearing them on a slide and having a look at them and seeing if you can tell whether it's benign or malignant. And another sort of wing of things that pathologists do are post-mortem examinations. So those are essentially examinations to determine the cause of death in patients who are unsure about or we want to confirm the cause of death for. I'm going to talk to you very, very briefly about what histopathology, how we form a slide on a piece of glass. So when a piece of tissue, such as a biopsy, is taken from a patient, first needs to be preserved. And the way it's preserved is by putting it into a chemical called formalin, which is a solution of formaldehyde, basically. Once it's started to become preserved, we have a look at it, we inspect it. and we select parts of that specimen for cut up. So for example, we wouldn't want to look at the whole of that lump that we described under the microscope. It would take you a long time, probably, depending on what size it was. You'd want to select some portions of it to have a look at, okay? We as pathologists select parts of that lump to look at, which will give us the maximum information, which can involve whether the edges of that of the piece of tissue that the surgeon has taken out are involved, and what actually is the lump itself. So these are some pictures of a colon excision. Okay, so the colon or the large intestine is a long tube, and you can see here the sort of the end part of that tube. And here we can see that right towards the sort of the bottom of the back passage, essentially, there's a rough area here, and the pathologist here has actually inked that rough area in different colors, so that if there happens to be a tumor inside that area, you can actually identify if there is any tumor left in that patient based on the color of ink that tumor would hit. And we would open up that specimen and we would look inside the colon, inside the tube, and we might find an area like this, which looks suspicious for a tumor. This is a breast specimen. So this pathologist is sliced into a mastectomy for breast cancer, and they have sliced it in a bit like a bread loaf, and they're looking through it to identify any areas that they're suspicious for cancer, so they can sample it and pop it into one of these little cassettes to have a look at under the microscope. Once that sample has been taken and once it's been cut up, specimens are processed and water gets removed, and the specimen is replaced, is embedded within this paraffin wax in something called a block. This is a biomedical scientist embedding some of that tissue in some paraffin, and that's what that tissue inside a paraffin block looks like. That's then sliced very, very thinly, so about 1/200th of a millimeter thick. And there's special equipment called a microtome that allows you to do that. And this is another biomedical scientist who is slicing that wax at very, very thin intervals to have a look at that, to sort of select the right portion of that to put onto a slide. It's then put onto a slide. So that thin little bit of wax is slapped onto a slide, and it's stained and covered with a cover slip like here. And then once we stain it, it turns pink and purple, like we can see on the glass slides here. So in many centers, what happens after that is those slides get scanned, and so we can look at them digitally on the computer. But in most centers, microscopes are still very much used, so the glass slide is still important. When we talk about microscopy, we mean light microscopy, and the stain that we most typically use is H&E, hematoxylin and eosin. Hematoxylin is basically basic, it's an alkali, and so it will stain acidic areas such as the nucleus, which has a lot of DNA in it, blue. Eosin is an acidic dye, and it stains the other stuff, anything that is basic, pink. So everything on the outside of your cell, your cytoplasm of your cell, is pink, and the nucleus, where all the DNA is blue. And this is an example of that. And all this blue stuff here, that is basically the nucleus of the cell. All this pink stuff here is some of the cytoplasmic material. So as well as the H&E stain, we've got a wide range of other stains which can be used to highlight specific organisms or substances. And this is an example of something called a PAS stain or a PAS stain. And what you can see here are strands of fungi. Okay, so these are fungi which are infiltrating into some skin, or I think some esophagus here. And you can see those very nicely and clearly with special stains. There's other stains we can do as well. So we can also look for specific proteins within our cells using a technique called immunohistochemistry. And it can help us further subtype tumors, for example. It can help us characterize tumors, and it can help us identify where that tumor has come from. So this is an example of a tumor which has been stained using H&E. And those are our tumor cells sort of scattered around here with a bit of blood in between. And this is an immunostained slide, which shows that some of those tumor cells have lit up very nicely in brown, which tells us what kind of tumor it is. And briefly, we can also do molecular tests to confirm certain diagnoses, direct treatment, and tell us how that patient is going to do. So there's a lot we can do with biopsies, a lot we can do with tissue that we're given. Histopathologists essentially are looking for a couple of things. Is the stuff that you've sampled, is it stressed? Is there something that's stressing it out? Is it inflamed? Is it infected, for example? And secondly, is that tissue growing normally? And there's various ways of talking about abnormal growth of your cells. But two of the terms that histopathologists use are dysplasia and neoplasia. Dysplasia basically means abnormal growth, and neoplasia means new growth. Okay, so for example, if you've got a tumor developing, then you might want to describe it as a neoplastic piece of tissue, a neoplasia, because that is new growth of tissue that wasn't there before. And there's a complex intermingled relationship between the way that tissue is stressed out and whether it develops into dysplasia or neoplasia, and also between whether that change in tissue causes clinical disease or not. And in terms of what leads to these processes, there are always a range of risk factors and triggers which can lead to these processes, these types of abnormal response or abnormal growth. And that clinical disease that happens as a result of all of this can progress. So ultimately, our job as histopathologists is to identify these things, identify what's causing the patient's clinical disease, in our case, what's causing that lump, and then identify if that lump is likely to progress and become worse, and ultimately you want to stop it from killing that patient. So neoplasias can be classified based on, so new growths of tissue can be classified based on essentially how it is predicted to behave. So really what we're doing as histopathologists is we're kind of predicting the future, aren't we? We're predicting the future. So we've got that lump, we're going to look at what the cells look like, but we need to predict what it is going to do in the future. One of the things that can help us identify how it's going to behave in the future is by looking at what kind of cell it originates in. So most new growths, most neoplasias arise in cells that you already have normally. Benign neoplasms are basically things that are, are less worrying than cancerous growths. Okay, so these are things that are non-cancerous new growths. These tend to grow slowly. They tend to be well circumscribed, so you could draw lines around them. They tend to look a little bit like the original tissue. So, for example, that lump in the breast, if that looked a little bit like breast tissue, then that might, for example, hint that it is more likely to be a benign neoplasm. They tend not to infiltrate into surrounding structures. So, for example, that lump that we described was nice and circumscribed. So, it was a bit like a sort of rubber ball. You could draw a line around it. If it was sort of spiky and you could see that it was going into the breast that was surrounding it, then you might want to be worried about destructive invasion in that case. Benign neoplasms stay where they are, so they might get bigger, but ultimately you're not going to find that same lump spreading, the cells from that lump spreading to other sites. And importantly, they are very amenable to surgical cure. So if we cored out that lump and we took it out surgically, then it would be unlikely, assuming you got it all out, to recur. Malignant neoplasms, so this is what I mean by the cancerous tumors that we asked you about earlier on. So they grow quickly, okay? They tend to grow quickly, and they tend to not be as well differentiated as the benign neoplasm. What do I mean by that? I mean that it wouldn't look as much like normal breast tissue, for example, as a benign neoplasm. They tend to invade and destroy the surrounding tissue. They tend to spread. So metastases refers to spread of that tumor elsewhere. So we've got two types of neoplasm now, benign and malignant. So these are both on the spectrum of the abnormal growth that I talked about histopathologists discussing. And some tumors are somewhere in between. Okay, so benign and malignant is not an absolute label. Some tumors can be sort of halfway between being benign and halfway being malignant. So the behavior of neoplasias is on a spectrum. Ultimately, as histopathologists, we are predicting what that lump is going to do in the future. This is an example of some colon. Okay, so what the do you remember the one that we saw earlier on, where we saw the sort of the end of the colon? If you looked at the surface of that under the microscope, you might see something a bit like this. And histopathologists have to have a good understanding of what normal tissue looks like. And on the left, we have some normal intestinal surface tissue, which forms these glands, which are a bit like test tubes in a rack. And those glands usually sit on the surface. Now, what we've got in this piece of tissue is the surface, the muscle, which defines where the surface is. Anything on that side is surface, and anything on that side is deeper within the wall of that intestine. And here we've got invasive carcinoma. So essentially what this is ugly looking glands. You can see that these glands on the right don't really look like the ones on the left. They're a bit darker, a bit more irregular. On the wrong side of the muscle, where they're not meant to be, and that implies that they have invaded and are potentially destroying the surrounding tissue. And this implies that it's likely to behave in a cancerous way. So this is a cancer. This is a colon cancer. This is an example of some benign breast tissue. And this is just because we've talked about breast in terms of our patients. So there's a lot of understanding of architecture, both in terms of what it looks like to your eyes and what it looks like under a microscope in medicine. And in this piece of breast tissue, we can see that there are, again, these glands here, and they're set within some fat, and they're forming these sort of grape-like bundles, which sort of drain into ducts, which are like little tubes, and that forms a normal piece of breast tissue. So that's a duct, that's some fat. This is another person's breast, okay? And this is an example of a breast cancer. Okay, and unlike the previous one, you can see that that structure is not there at all. What we've got are sheets of cells, sort of not quite, in a quite haphazard fashion. And I haven't shown you the surrounding tissue, but they are infiltrating into the surrounding tissue, destroying it. And this has the propensity to go bad, to spread to different sites and kill this patient if it was untreated, for example. So pathologists are telling you the difference between benign tumors and malignant tumors and telling you if they don't know if it is benign or malignant. Once you've identified a tumor, you may want to give it to, you want to characterize it as well. And an example of how we might characterize a tumor is grading and staging. So the breast cancer that we saw in the previous slide, it could be low grade or it could be high grade. And actually that tumor looked like it was going to be high grade. Grading is how aggressively that tumor is going to behave. And what do we mean by aggressiveness? Well, if you create a bit of a metaphor and you say that there's a start line and a finish line and there's a marathon in between, and that finish line is sadly when the patient passes away or has a very, very poor outcome. And the start line is someone who's perfectly normal. If you've got a tumor that is high grade, then it means that you're progressing very quickly along that path. If you've got a tumor that's low grade, it means that you're progressing more slowly along that path. Staging is another thing that we do with tumors. So basically, all that tells you is how far along that path that tumor has gone. So a bigger tumor in many cases is higher stage, or a tumor that is invaded into lots of surrounding structures rather than just a few is high stage. But you can also have tumors that are low stage, so haven't gone that far along that path towards a bad outcome, but are high grade, so they're moving quickly towards it. Or you can have ones that are further along that path, but are moving a bit more slowly. And both of these are things to worry about, aren't they? So high grade or high stage are things to worry about because you want to stop that tumor from reaching that finish line. So I just want to go back to our case now. So our 32-year-old woman has described this lump in the left breast, and we've talked about it. It's painless, it's firm, 2 centimeters in size, and it's smooth and mobile. And what I'm highlighting is some of the things that doctors will be looking at to help you characterize that lump even before the histopathologist has had a chance to look at it. So the patient is quite young. And in many cases, such as in breast cancers, older patients have a much higher likelihood of developing malignant tumors. So the fact that the patient is relatively young in the grand scheme of things is actually quite a reassuring thing. The fact that it's painless and firm doesn't tell us that much about the tumor. Many benign tumors are often painless. The firmness doesn't tell us that much information. 2 centimeters is not that big. Okay, so maybe that size is slightly reassuring to me as well. You examine the patient and you note that it's smooth and mobile. So the fact that it's smooth, as we've discussed, means that you could draw a line around it. So it's unlikely to be invading into the surrounding tissues. So you could pluck it out, and that is a nice feature of benignity. Okay, the fact that it might be benign. Mobile is also a good sign because it means that it's moving around in the surrounding tissue. If it was forming little tendrils going out into the surrounding breast, it would be stuck to it. Okay, so the fact that it's mobile is a good sign. Now, often our patients don't give us all the information that we would like. She does not think the lump has changed in size, but is unsure. It's probably a good sign that she doesn't talk about this lump growing much, much bigger in the last few months. If it had, then perhaps we would be a bit more concerned about it. So what does the pathologist do? The pathologist, the first step before the pathologist gets to it is, of course, the surgery. So the surgeon would have to identify that lump, and they can do that on something like a mammogram that we've got here, or an ultrasound scan, which I'm not showing you here. And you can see that little lump in the breast there. And once they've identified it, they've characterized it, they may choose to biopsy it, to take a small piece of that lump out, or they may choose to do this, which is excise the whole lump. Okay, so the surgeon in this case has taken out the whole of that nice smooth lump that we have described. So we've got that. So the first job of pathologist is to look at that, describe it, and slice into it to select some pieces of that tissue to look at under the microscope. So the pathologist does examine that and diagnoses a fibroadenoma. So this is what the pathologist might see under the microscope in a fibroadenoma. And we can see that it does have its resemblance to normal breast tissue. So we can see that there are some of those tubes that we talked about, those little straw-like tubes. Can't quite see the little clumps of grapes on the side of it. Maybe there's one there. It's a little bit blurred, sorry about this picture. But we can see the tubes. And you can also see the fibrous tissue that is embedded in it. It doesn't look quite normal, does it? There's a lot more fibrous tissue than you would expect in the normal breast, but it is there. And the other thing we can see is that there's a nice straight line down the side of that tumor. So it means that it's been cored out nicely. Okay, so back to the thumbs. Any of you concerned that this is a definitely cancerous tumor now, based on what I've told you? No thumbs up. Anyone want to go for 2? Definitely not cancerous. Anyone at all? One person? Well done, Thelma. Anyone unsure? We've still got a few people who are unsure, I think. So I think you're perfectly correct if you call it something that is definitely not cancerous. So the whole process of histopathology is combining all the clinical information that we have with the appearances under the microscope, which tell us what it's likely to do and how it's likely to behave. So the word fibroadenoma, fibro means that it's got a fibrous or stromal component. We saw a bit of the fibrous stuff surrounding the straws, the tubes in the previous slide. Adenoma suggests a benign glandular tumor. So the breast is essentially a big glandular organ and and the word adenoma means that it's likely to be a benign tumor of glands. So how did we conclude that this was benign? So the history features we've discussed: smooth, mobile, not increasing in size. The radiological and macroscopic features. So we saw the scan of our patient, the X-ray of our patient, and it looked round and it looked quite homogeneous. So it looked kind of the same all the way through. And our histopathology, which has ultimately confirmed our diagnosis and said that this is a fibroadenoma. So hopefully that gives you somewhat of an understanding of what we do. And it is a bit complicated, actually. There's a lot of different steps in what we do, and it's something that a lot of doctors actually are not entirely familiar with and know a huge amount about. So the question then arises, why did I choose histopathology? So I think a lot of people go into medicine wanting to interact with people, with their patients. But a lot of people also go into medicine because they're interested and excited about science and how the body works. And histopathology is one of those specialties that is fantastic for looking in detail at how the body works. You learn a lot about disease in medicine, and you learn a lot about different processes and different diseases and how to identify those different diseases. But the easiest, in my opinion, the most definitive way to actually identify what is actually wrong with someone is by looking at that the person's tissue, looking at what is actually happening at both a macroscopic and a microscopic level. And it's that sort of detective process of identifying what is actually causing someone's problems that attracted me to histopathology as a specialty. Histopathology is an interesting specialty in that you don't actually directly see patients. At least most histopathologists don't see patients. And I wanted to bring that to your attention because it shows how diverse medicine is. So most doctors will see patients, but you can do a medical degree and you can progress through a career in medicine without having to see patients. Alternatively, you can be very, very patient focused and you can choose specialties which have a much more direct interaction with patients. But in histopathology, we don't speak to or see patients directly. We see bits of them. We see the biopsies, we see the resection specimens that we've got in front of us. But like all doctors, our first concern is the patient. And just because you don't get to see the patient and you don't get to directly interact with the patient, doesn't mean that patients are not ultimately our first concern. What we are doing is using our understanding of biology, of the appearance of disease to help our patients in the best possible way. So the take-home messages, if I want to give you some take-home messages from this, is that yes, doctors do come in all shapes and sizes like you've seen, but all will make patients their first concern. And if you're thinking about things like interviews, personal statements, things to put in your applications, the patient needs to be your first concern at any point in this in that application. There's other things that you might be interested in, but the patients are your first concern. And the second thing is histopathology. Medicine is a very, very long journey, as we've discussed. But a lot of you will have different sets of skills, and you might be wondering, well, I'm not very good at this, but I'm better at that, and I want to do this, and I don't really want to do that. Medicine is a very, very flexible career, and there are niches and specialties within medicine that will adapt, that you can use. You can basically select your specialty in order to adapt to those skills and your preferences that you have. So don't pigeonhole yourself into thinking that all doctors are going to be the same. Medicine is all about flexibility, and it's about branching out, and there are many different opportunities along the medical path in order that you can use to branch out and adapt your career to your own skills and preferences. So that's pretty much all I have to say. Does anyone have any questions or anything else they would like to add? But I think I'm finished with the sort of the talk part of my presentation. Thank you. I can't hear you, but it might just be me. There, I can hear you now.
Okay, I was just saying thank you for such an excellent talk. I think it's really important to. Right, sorry about that. What I was going to say is that pathology is such an important thing to understand going through medical school because it does kind of underpin everything you see in the hospital. So even if you were thinking, oh, I want to do this certain thing in a primary or secondary healthcare setting, like a GP or a mainstream hospital, it's still pretty important to know the fundamentals of pathology. And indeed, as I'm sure all of you know, cancer is such a big, unfortunately, it's such a big part of health and disease around the world. So yeah, some very, very important things to learn there. And I would also echo Dr. Ghosh's words that you don't need to pigeonhole yourself into one area of medicine. And many people, even when you come to the last years of medical school, when you've started basic training, still don't know what they want to do, and that's not a problem because essentially we all want to do the same thing and improve patients' lives, and we're all differently skilled to do that more effectively in different areas. So definitely be aware that there is not one type of medicine, although there is a unified goal. And I just wanted to ask you just one question, because this is also something that I only learned relatively late into my second year, or really acknowledged, was the difference between benign and malignant in terms of a mass. Would you say there's a definite criteria there? Because I know you mentioned there's a spectrum, but I wondered if there's a more concrete criteria.
I mean, in many ways, there is no sort of definite concrete criteria. There are some. What we do is we build up evidence for something behaving in a bad way or a malignant way, and for evidence for things behaving in a benign way. The A lot of people sort of decide that if something spreads, if something metastasizes, that is the ultimate definition of whether something is malignant or cancerous or not. Unfortunately, as a pathologist, I have learned of several entities that are able to spread, but are not defined as malignant. So that, it's just an illustration of the fact that there are nuances amongst, in all of these specialties, and actually it's sometimes very difficult. However, there are a lot of conditions which, like the sort of breast cancer that we saw, like the adenocarcinoma that we saw, which the appearances are so characteristic and so aggressive looking, and that actually we can be definitive and call those as malignant. But but I would say there is no single criterion. If someone was to ask you for a single criterion, the concept of metastasis is probably the one to mention. But not all doctors know this, but there are some tumors which can spread despite not being defined as malignant. So good question.
Right.